the mother. Maternal undernutrition, reflected as low body mass index often, is a very important and prevalent condition. There are also a number of less obvious micronutrient deficiencies, such as vitamin A and iron. And these conditions can lead to problems in the mother, health problems for the mother, but also intrauterine growth restriction, leading to what we commonly think of as low birth weight, but the poor fetal growth as a consequence. Just a few definitions. Stunting and wasting begin early, as I'll discuss more in a minute, but stunting is the chronic restriction of growth affecting height and indicated by a low height for age. Wasting is acute weight loss, reflected as low weight for height. And both of these are usually caused in somewhat different ways by insufficient diets and by high rates of infectious disease in childhood. This is a map of the picture in regard to stunting, the prevalence of stunting. As you see, the prevalence in some parts of the world, especially South Asia and Sub-Saharan Africa, is very high, with more than 40% of children being stunted. We also have done some calculations that indicate that 90% of all stunted children live in just 36 countries, indicated here on the map, again, concentrated in South Asia and Africa. There is a very high prevalence of these conditions. Intrauterine growth restriction affects 13 million babies born each year. As I said, there's 198 million children with stunting. That's 32% of all children in the world, and 19 million children who are severely wasted. In addition to examining the effects of these conditions, the short-term effects on mortality from infectious diseases primarily, we also use another metric called Disability Adjusted Life Years, or DALY. This is a summary measure that combines both death and morbidity and disability to allow further calculations, such as how much human capital is affected by these undernutrition conditions, such as stunting. So one DALY is equal to one lost year of healthy life. The burden of disease that we've calculated in terms of deaths and DALYs, first we look at intrauterine growth restriction affecting the newborn, the life actually, stunting and wasting, severe wasting, so that we can combine these into a common measure related to the nutritional status of a child. And we say that that these conditions are responsible for more than 2 million deaths and 91 million DALYs, which is about 21% of the total burden of disease for children under 5 years of age. This also represents 7% of the global burden of disease from all conditions in all ages, which is the largest fraction for any risk factor, including smoking, including unsafe sex, anything else that has been looked at as a risk factor. This is the largest for any risk factor of all ages. In addition to these conditions of body size, there are also micronutrient deficiencies. This is a map of the prevalence of zinc deficiency, which is quite high in many parts of the world. And following that is a map of the countries affected by vitamin A deficiency. We've calculated that vitamin A and zinc deficiencies together account for the largest remaining disease burden among the micronutrient deficiencies, with a combined total of about 10% of the global childhood DALYs. In addition to these, iron deficiency has particularly severe consequences for women in pregnancy, and by these calculations causes about 115,000 deaths, or about 20% of maternal deaths. We've also examined suboptimal breastfeeding as a nutrition-related condition. And on this histogram, in the light blue would be exclusive breastfeeding. The recommendations currently by all of the international bodies would be that all children in the first 6 months of life should be exclusively breastfed. As you can see, that bar on the panels on the left by region for the first 2 months of life would be 40 or 50% only, and after that for the months 2 to 5 falls even further to only 20 or 30%. So there's still a great room for improvement in the practices of exclusive breastfeeding. We've estimated that these suboptimal breastfeeding practices are themselves responsible for 1.4 million child deaths and 44 million global DALYs. Again, about 10% of all childhood DALYs. So the key messages for this paper are that together, as Faith said, these risk factors are responsible for more than 1/3, about 35% actually, of child deaths and 11% of global disease burden. We've done a variety of methodologic improvements that have now eliminated double counting. We've looked at joint effects of all these, and we've looked at things in a different way with new data, including the new WHO growth reference. We also indicate that as far as deaths, 3.6 million mothers and children die each year. And we think, of course, that this high disease burden justifies and provides a really compelling case for interventions globally. The second paper looks at the long-term effects, and this I would just summarize briefly to say would be the relationships between maternal and child undernutrition and the adult outcomes, which would be height, schooling, the obesity or diabetes measures or high blood pressure, and then further review of a number of other conditions. But there are many new analyses here resulting from the pooled efforts of the leaders of 5 international long-term cohort studies where children are followed from birth to adulthood, and the risk factors from early undernutrition, fetal or early childhood undernutrition, can be examined. So I'll just present quickly the conclusions of this. Undernourished children are more likely to become short adults and, in the next generation, to give birth to smaller babies, who are themselves then at higher risk of these outcomes, the adverse outcomes. The evidence further links stunting to cognitive development, intellectual capacity, school performance, and educational achievement, commonly referred to as human capital, or at least a component of human capital. Poor fetal growth or stunting in the first 2 years of life leads to reduced economic productivity in adulthood, and the child's height for age at approximately 24 months is the best predictor of human capital. Also has been interest in issues related to weight gain and when is it good and when is it bad. From the additional analyses done as part of this series, it's been shown that children who have early undernutrition, early growth restriction, fetal or early childhood, and then gain weight rapidly later in the later preschool years or in school years, are more likely to have high blood pressure, diabetes, and cardiovascular and metabolic disease, such as other than diabetes, when they're adults. So these are very important consequences. We've tried to quantify but haven't summarized the measures, but that is work remaining to be done. But we also showed that there is no evidence that rapid weight or length gain in the first 2 years of life increases the risk of chronic disease. So that is to say, if a child is born with intrauterine growth restriction, don't hold back on the growth at that point, fearing bad outcomes further. The nutrition in the first 2 years of life is critical, and rapid weight gain at that age group is not a problem. The key messages here are that stunting, underweight as well, in the first 2 years of life leads to irreversible damage into adult life. Children who are undernourished and gain weight rapidly are at high risk later of chronic disease, but this is not a problem in the first 2 years of life. And the prevention of these early maternal and early childhood undernutrition conditions will be a long-term investment to benefit both this generation and the children of this generation. There's a very extensive analysis in the third paper related to interventions, reviewing systematically 45 possible interventions that might affect maternal and child undernutrition. The examples of those are illustrated on the right, and I don't have time to go into them, nor actually to the details of this, but this is a listing of the interventions, 14 of them, that affect maternal and birth outcomes or affect newborn babies or infants and children after the first month of life. And these are interventions that we have concluded from the extensive review of the literature and further analysis that these are proven interventions and basically can be implemented virtually everywhere. There is another set of interventions, 11 on this list, that are we call situational interventions or interventions for situational context. Of course, these would be situations where there's food scarcity, food insecurity. They would be situations where there's vitamin A deficiency or high rates of malaria or high rates of intestinal worms. And in those situations, these would be considered proven interventions as well. So in total, there are 25 interventions considered by the series to have sufficient evidence of benefit to be implemented. So these interventions would provide benefit, but the ones showing most promise, we would say, are breastfeeding promotion, appropriate complementary feeding, supplementation, or in some cases fortification with vitamin A and zinc, and appropriate management of severe acute malnutrition. The key message is here we have interventions that work. If we implement these at scale, and there was extensive modeling as part of this paper, which you can see in the printed version, we estimated we could reduce all-child deaths by 1/4 in the short term and reduce prevalence of stunting by 36 months of age by about 1/3. And again, conception through 24 months of age is the critical window. The efforts to look at national programs focused on 20 countries. I mentioned the 36 countries, which is 90% of all stunted children in the world. 20 countries is 80% of all stunted children in the world, so that the top 20, if you will. And we looked at what were the programs currently in existence, how extensively were they implemented, and as you see, it's a little bit hard to see this figure from the paper. These are interventions that are being implemented, some with moderately high coverage, such as iodized salt or vitamin A supplementation, some with, at least at the time this was put together, very low coverage, such as malaria prevention, and some that are not on here because they're hardly implemented at all, such as zinc supplementation. And so there's a general statement that the programs in countries are generally failing to reach high enough levels of coverage to be effective to address these problems. So there are a number of challenges identified in the paper 4, getting on the national agenda. Most countries, in fact all of these countries, the 20 we looked at, have a national policy or plan on nutrition. But in fact, many of these statements in the plan have not been implemented or not implemented at high coverage. And in some cases, as I'll discuss later, even include things that we would consider not the highest priority. Doing the right things, I guess we would hope this series would provide some guidance, what we think may be right things, but clearly these are national decisions with some support and assistance from international agencies. So countries need to think for their own settings, what are the right things to do? I would just say a word about not doing the wrong things. That seems an obvious statement. But one of our conclusions in this series is that there are, in many cases, examples of, one might say, mistargeting of nutritional assistance. Of these 20 countries, 10 were implementing feeding programs for preschool children at greater than 24 months of age. And all 20 countries were implementing school feeding programs. Now, it may be that these programs, in fact, there is evidence that these programs have some benefits that are non-nutritional for education, for example. But as nutritional interventions, we don't think this is good targeting, and especially in countries where there's not attention in the first 2 years of life and there is attention to older children, we think these programs should be reconsidered, and they will not prevent or reverse undernutrition, and perhaps there should be a refocusing on the first 2 years of life. Of course, to affect the entire population in need, one has to act at scale, and one of the problems with many of these interventions is they are not delivered at scale, and they are not necessarily targeted right to reach the poor or by age, as I've said. We believe that evidence can influence policy and programs and can help guide the improvement of programs, and there's important work to be done on monitoring and assessment and public accountability. There is a great need to build capacity, and that capacity in country can be both individual and institutional. Many of the countries that were assessed basically said themselves that we don't have the capacity to do this. So these are the key messages quickly. The national nutrition programs should effectively monitor and evaluate target populations that benefit most. Countries should focus resources on intervention effectiveness and implement them at scale. There are a number of other aspects of what you might not call nutrition programs, but nutrition comes strongly into it, or it should. Economic and social policies related to poverty, trade, and agriculture, and other aspects related to social programs that should include nutritional aspects. The fifth and final paper looks at what we've called the international nutrition system. Not formally a system, but in fact many aspects are what you would think of as parts of a system, and ask what are these components, what should we expect of them, are they fulfilling that expectation, and what are the problems if they are not. These are the four functions. This has been used for health systems. We thought it applied to a nutrition system: stewardship, setting standards, identifying priorities, resources, mobilizing them, figuring out how to allocate them. Capacity, as I've mentioned, both for policy and for implementation, as well as research and further improvement. And then the service provision, of course. This actually, as far as the international system, focuses more on direct service provision, such as humanitarian emergencies, rather than the national level dealt with in paper 4. A rather bold conclusion, and I hope one we can substantiate if you ask me, is that there are numerous international agencies, and in fact we have enumerated them. There are many UN organizations, many development banks, many other regional and national organizations, bilateral donors, NGOs, foundations involved. I think our conclusion is that the current coordination is poor. The current processes do not deliver consistent normative guidance that is prioritized and evidence-based. Generally, program evaluation is weak. There is insufficient analysis of the global challenges, even beyond the sort of very specific nutrition challenges, such as climate change or trade or migration, or various broader issues that will affect nutrition, but there's not very much analysis of that, and too little investment in human and institutional capacity. And finally, funding is grossly inadequate. We believe it is poorly targeted, and it's too dominated by food aid and by technical assistance. We've called for a improvement in the international architecture, including a new global governance structure, a more effective relationship among the UN organizations and between the organizations and others, fewer parallel actions by these organizations, and some filling of gaps in mandates, more investment in capacity, and more leadership on research. The key messages here are that the international nutrition system is fragmented and dysfunctional, and reform is needed for this to be more effective. We think these problems are longstanding. They're embedded within organizational structures, but a concerted effort on this can provide greater progress and greater accountability, and that more funding really is needed, and it needs to be better targeted to meet the needs in basic nutrition programs. We just close with this statement that we believe progress is possible. We have called strongly for it if nutrition becomes a priority and if the world community is willing and able to do the right things. Nutrition is a central component of human, social, and economic development, and we think that these improvements will lead to achievement of MDGs 1 on poverty and hunger, and 4 and 5 on child and maternal mortality. I would just put up for recognition the very large group of individuals who have worked as part of the writing team for this series, and many others who contributed to it, many of you in the audience, but many others who have contributed information and their own perspectives on this. So I would thank you and end there.
Thanks to Dr. Black. And now I'd like to invite our panelists to the stage. Would you welcome Dr. Joy Pumapi, Dr. Kent Hill, Mr. Jay Naidu, and Dr. Tachi Yamada. Our next speaker is Ms. Joy Pumapi of the World Bank. Dr. Pumapi of Botswana National is Vice President of the World Bank's Human Development Network. Before joining the bank in February 2007, she served as Assistant Director General for Family and Community Health at the World Health Organization in Geneva, where she managed a global staff of more than 1,100 and represented the World Health Organization on the board of the Global Alliance for Vaccines and Immunizations, Gavi. Please welcome Dr. Joy Pumapi.
Thank you very much. I feel that with this expose that has been given to us this morning, there's really very little for us to add except to applaud the work that has been done and to reflect on what the responsibilities and the implications are for all of us in the development community. Less than 2 years ago, the bank released a seminar report on repositioning nutrition as central to development. This report had tremendous impact inside the bank on the way in which we redefined our work in this particular area. But it also had tremendous impact on the way in which we worked with our client countries and therefore the way in which we collaborated with other development partners. It is clear that malnutrition and indeed nutrition as a whole is an economic imperative. It is an economic imperative because, as you have just heard, there are direct losses in productivity from poor physical status that result from undernutrition and malnutrition. There's indirect losses from poor cognitive function and deficits in schooling that also result from malnutrition and undernutrition, and losses owing to increase in health costs, and therefore catastrophic implications and driving people into poverty because of the increases in health costs. Addressing undernutrition and micronutrient malnutrition is a poverty reduction strategy. That is our point of view. It is also very, very clear from the expose that you have just received that the two-way relationship between nutrition and incomes is not as widely understood as we otherwise thought. Higher incomes do improve nutrition, but only slowly. And it is very, very clear from the expose that you have been given and the series that has been launched today that direct investments in nutrition have the potential to improve nutrition outcomes much faster than economic growth alone can. That is very, very clear. And it is because of this that we must ensure that improving nutrition that we know increases economic growth must become a pivotal component of our development strategy as development partners. Bigger and healthier bodies lead to higher physical productivity. Well-nourished children are more intelligent, they are better learners in school, they are more productive as adults, and a well-nourished population spends less on health care. The economic benefits from improving nutrition are substantial. We have learned historically through research and as evidenced by this series that for individuals, they average at least 10% of lifetime earnings. And for economies, they can make a difference of 2 to 3% of the gross domestic product. This is substantial. But the implications of this for us as a development community and for us in the bank is not only that we must invest in nutrition, but we must be more strategic in the way that we invest in nutrition. We must not only integrate it into the other areas of investment. We must not only build capacity in countries to address this issue in a much more effective manner. We must not only scale up knowledge, whether it be in research or in tools and interventions that work, and as well as monitoring what works and scaling it up. But we must also ensure that it becomes pivotal to the other areas that are indicated by lack of food security, such as the areas in trade and such as the areas in climate change that are currently very, very pivotal to development. The undernutrition agenda, therefore, is increasing recognition of the importance not only of addressing undernutrition and malnutrition, but the challenges such as those of obesity and related non-communicable diseases. There is a strong interest within the bank to engage more actively with you as global partners and with our client countries in these areas in a multi-sectoral manner and in an integrated manner, making sure that we link research, social protection issues, gender, early childhood development investments, environment and climate change investments with investments in nutrition. And we do agree with the conclusions that have been reached in this series that there are huge implications for the architecture of the international nutrition system, and that these implications must be addressed effectively by all of us, that we must make up a more concerted, we must make a more concerted effort to ensure that all the international organizations, that whether they be academia, civil society, private sector, ourselves as developing institutions that are currently fragmented and therefore are leading to a dysfunctional agenda in this area, come together and ensure that we establish a new global governance structure that can provide greater accountability and participation of all societies in order to ensure not only that we reach MDG 1, but that we also attain MDG 4 and 5. But to some extent, we'll have to invest tremendously in MDG 2 as well. And of course, there will be some benefits for MDG 6. So as the World Bank, we would like to associate ourselves with the recommendations that have been made by this group. We would like to commit to ensuring that we implement these recommendations, and we would like to commit also to increased investments and collaboration and harmonization with you and the rest of the global community in this critical area. Thank you.
Thank you very much. It's now my pleasure to introduce Dr. Kent Hill, who is Assistant Administrator for Global Health at the U.S. Agency for International Development. He was confirmed by the U.S. Senate in October 2005, and he's responsible for a bureau that manages or co-manages health programs all over the world with funding of nearly $2 billion. The Bureau seeks to provide global leadership in the effort to improve the quality, availability, and use of essential health services, and focuses its efforts on HIV/AIDS, avian influenza, other infectious diseases, family planning, environmental health, and of course, maternal and child health and nutrition. Please welcome Dr. Kent Hill.
Thanks, Dr. McClellan, and Dr. Black, thank you for your presentation, and fellow panelists, and the folks from Lancet and the Wilson Center, thank you so much for hosting this. Of all the things that have been on my agenda and are on my agenda for this week, this is the event I most look forward to, and I'm glad this morning has finally come. According to the World Food Program, 852 million chronically hungry people live in the world today, and roughly half of those folks are children. Even though many children eat enough to fend off hunger, some do not get the nutrients they need for growth and development. Women and children commonly make up the most vulnerable segment of societies with high rates of undernutrition. Improving the health and nutrition of those living in the poorest countries of the world is the focal point of USAID's Global Health and Nutrition Program, and key to reducing the crippling healthcare costs and increasing national productivity. For more than 30 years, USAID has supported programs to prevent malnutrition, stunting, and micronutrient deficiencies. The USAID spends about $30 million a year for nutrition programs to include vitamin A, iodine, food fortification, anemia packages, and zinc, or rehydration therapy, etc. We did a lot of the initial research or cooperated with it to produce these interventions which have such an amazing impact. The U.S. is also the largest food aid donor in the world and the largest single contributor to the World Food Program. The U.S. procures, ships, stores, and distributes and monitors and evaluates approximately 2.5 million metric tons of U.S. food aid each year, worth over $1 billion. I might mention that between 40 and 50% of the Title II non-emergency resources support multi-year, community-based maternal and child health and nutrition programs. I want to also add something here that's not in my notes, but I know from the research I've done and what I've read, it is critically important to do what some of the other panelists have talked about already. It's not to just address these issues when they've already reached crisis proportions where you actually see it. You really need to deal with these nutrition issues long before it's obvious and start at the very beginning of life, particularly up to those first couple of years, to address this. Through the Global Alliance for Improved Nutrition Gain, USAID is directly supporting 22 programs in 19 countries around the world that fortify staple foods and condiments like fish sauce in Vietnam and cottonseed oil in Burkina Faso with iron, iodine, vitamin A, and other micronutrients. Food fortification is extremely important and it's very cost efficient. Every dollar spent on vitamin A fortification returns about $7 in increased wages and decreased disability. A dollar spent on iodized salt returns $28. Iron fortification returns $84. Hard to believe. At USAID, our philosophy is that improved health for the world's poorest people is not only a moral imperative, but also a pragmatic investment for peace, security, and worldwide economic growth. Health is strategically important to the success of virtually every other aspect of a good and solid development portfolio. Health status, in fact, is the single greatest indicator of poverty. Good health lies at the base of stable workforces and productive economies. Public-private partnerships unite the skills and the resources of each partner and apply them to development challenges for a sustainable solution. And that's why we have particularly embraced this approach in the last several years. Since 2001, our public-private partnership initiative, the Global Development Alliance, has created about 600 public-private alliances with 1,700 partners. Some of these are in the areas that we're talking about here this morning. Forging a strong alliance of collaborators from among national governments, international agencies, the private sector, and other sectors of civil society is a key component of a global and USAID nutritional program agenda. As we look ahead, USAID will increase its efforts to work with other agencies and host country counterparts in food and nutrition policy, strategy, and program development and implementation. We do so because coordinated efforts in public health have resulted in marked declines in infant and child mortality, a narrowing of the gap between desired and actual family size, increases in life expectancy that almost match the rates of developed countries, particularly in Asia and Latin America. And I want to add this as well. It's the nature of our business to be aware of where the problems exist. But the reason we know what interventions to do is because of the successes the international community has had over the last few years in figuring out what will help most. And although we celebrate moving forward, we also celebrate the successes and the foundation upon which we work. And finally, it is my hope, it is our hope at USAID that this series of papers, bringing together the wealth of information on nutrition, will help to raise awareness, expand and deepen support for maternal and child nutrition at the donor, policy, and program levels in countries that face the most serious nutrition challenges. Thank you for the invitation to be with you at this occasion.
Thank you, Dr. Hill. Our next speaker is the chairman of the board of the Global Alliance for Improved Nutrition, or GAIN, an organization working to reduce malnutrition through food fortification and other strategies aimed at improving the health and nutrition of at-risk populations. Jay Naidu is also the chairman of the J&J Development Trust, the social development arm of the J&J Group, which is a diversified investment and management group headquartered in Johannesburg. He is also the chairman of the Development Bank of Southern Africa, a key financial institution driving the expansion of social and economic infrastructure in the Southern African Development Community region. Please welcome Jay Naidu.
Thank you very much, Faith. I have a confession to make. I am not a nutritionist, I'm not a scientist, and I'm not a researcher. In fact, I'm an ex-trade union organizer. And I think one component of what's been alluded to in this great challenge that faces us globally is where are the people who are most affected. And I think one of our most important experiences I can testify to is the involvement of the people most effective in taking their lives and their destiny into their hands. And I think it's every parent, no matter what their status and whatever their lifestyle, whatever their wealth or their poverty, wants the best for their children. And so I live in Johannesburg. I'm one of those that crossed the Atlantic to come to this launch, which is a very important part of what we believe is our reality. Because our reality is that we have an AIDS pandemic sweeping our region. In South Africa, my own country, we have more than 5.5 million people suffering from AIDS, HIV/AIDS. The Medical Research Council of South Africa estimates that close to 1,000 people die every day. And if one looks at the consequence of this, over 1 million children today have either lost one or both of their parents, with 80% of new infections being women. And in the most vulnerable group, the 18 to 24-year-olds, and that 1 in 3 women today attending the public clinics are HIV positive. That is our reality. And many of these people come from the poorest communities, in our rural areas, in our informal settlements, where even in the rural areas, subsistence agriculture, which has been sustaining many generations, is declining. So everyone knows today that even if we had to have everyone on antiretroviral therapy, proper nutrition is a prerequisite. In fact, there is growing evidence that in the absence of proper nutrition, more and more people who are on treatment are abandoning that treatment because of the side effects. So the question that confronts us today is what do we have to do? And it's no coincidence that GAIN was in fact launched as a partnership of the public, private, and community sectors by Bill Gates and Kofi Annan in 2002 at the UN Special Session on Children to fight malnutrition that affects close to 2 billion people in our world. Over the last 4 years, we have implemented mass fortification programs that addressing micronutrient deficiencies in over 20 countries, many of which almost overlay the countries that have been identified in the report, and which, when at scale, will reach close to 650 million people, focusing on countries, on sub-Saharan Africa, the Indian subcontinent, Southeast Asia, and Eastern Europe. We have also, over the last 4 years, worked very successfully with the business community in order to harness their technological, their managerial, and the distribution capacities and capabilities in order to develop new products that meet the needs of the poor at the base of the pyramid. And it is, as alluded in the report, it is precisely this innovation and amazing potential that we need to unlock in order to combat malnutrition. We are now working with over 400 business leaders at a global, national, and local level to use market-based innovation to develop products in our fight against poverty. In fact, today, we are proud to announce an exciting new initiative in partnership with the Bill and Melinda Gates Foundation, where a new grant of $38 million will enable GAIN to work with the private sector on innovative business models for our new program on infant and young child nutrition for the lifespan of 6 to 24 months. We again concur with the report that the first 6 months of a child's life should be exclusively focused on breastfeeding. And we have constantly reiterated this. We are working, as the report suggests, to broaden the donor base that is contributing towards the nutrition agenda in both the public and private sector, working with organizations like USAID, with the World Bank Group, with UNICEF, the WHO, and with an increasing greater range of private sector players to build the business case for investment in products that address malnutrition. So one of the most important constituencies I can see identified out of the report certainly has to be harnessing the role of women and mothers in particular. In GAIN, we are committed to working with and empowering women's groups to strengthen the fight against malnutrition. I've seen this make a difference even in my own country, where thanks to flour fortification with folic acid, vitamin A, zinc, We've already achieved a 30% reduction in neural birth defects and a 65% decrease in prenatal mortality rates from neural tube defects. So already a focus on evidence-based delivery. And that's what, in a sense, GAIN as an alliance working with its partners is moving towards in terms and support, again, of the report, calling for greater coordination. At the same time, we have to make the point that we have to build linkages. Again, something the report alludes to, between the nutrition issues and global issues around AIDS, water, education, women's rights, global warming, global trade, and agriculture, just to name a few. We need to position nutrition in all of these visible agendas. Efficient nutrition programs will help most countries meet the MDG targets, for instance. And here I think we are quite keen to focus on policymakers and decision makers. How do we intervene in the processes of budgeting, using parliaments, using pressure groups, using advocacy groups? Finally, a new architecture, as the report suggested, is necessary for the nutrition sector. It is a very fractious community, and I think my view has been that, and the discussion within GAIN has been, we've got to involve more than the nutrition community in raising the profile of nutrition on the global radar screen. We need to make sure that in whatever we create, we also have to ensure participation of the private sector. And here, it will be difficult to create public agencies or institutions and then go out and seek the support of important constituencies, whether these are women's groups or whether these are the private sector. We need to bring in business and any other sector into the discussion at the earliest stages of creation of the new architecture in order to integrate their views and secure their full commitment. Very important in all of this is the role of media. And the Lancet series and certainly has raised the media profile of nutrition. So what we need to do is take this amazing piece of work and translate it into practical, measurable results that can impact on the lives of people across the world. I am tremendously encouraged by the response we are beginning to see to the report. And finally, our action or lack of action can mean the difference between life or death for millions of people in our global village. Because if you look at the reality of my own country, which is relatively well developed, we have a situation where 1 in 10 people today suffers from HIV, compared to a country like the US, where it's 1 in 250. As a developing country, emerging from centuries of racial oppression with limited resources, we have to confront this problem. So all I can say, arising from this report, GAIN is committed to working with the partners involved and mentioned in the report in order to achieve the vision that we all have set, a vision of a world free of undernutrition. Thank you.
Thank you, Mr. Naidu. Our final speaker this morning is Dr. Tachi Yamada, the president of the Bill and Melinda Gates Foundation's Global Health Program. In this role, Dr. Yamada leads the foundation's efforts to help develop and deliver low-cost, life-saving health tools for the developing world. He also oversees the foundation's global health grant portfolio and global health advocacy. Dr. Yamada is a past president of the American Gastroenterological Association and the Association of American Physicians, a master of the American College of Physicians, and a member of the Institute of Medicine of the National Academy of Sciences in the United States and the Academy of Medical Sciences in the United Kingdom. It's my great pleasure to welcome Dr. Tachi Yamada.
Thank you very much, Dr. McClellan. Thank you, Dr. Black, for the outstanding work that will lead to a wonderful series in Lancet. The discussion here is on nutrition, a subject near and dear to my heart since I'm a gastroenterologist. The Gates Foundation, as you know, has devoted its resources to addressing health inequities. And in this area, we really have many things that we can do, but we've focused on just 3 principal areas. They are infectious diseases, maternal and newborn child and reproductive health, and nutrition. And the key to nutrition is that nutrition really binds all of our programs together. Because if one thinks about infectious diseases, one has to understand susceptibility to infection is directly related to nutritional status. Mortality from infectious diseases is directly related to nutritional status. If one thinks about maternal and newborn child and reproductive health, if one thinks about the Millennium Development Goals 4 and 5, they are not achievable unless we address the issue of nutrition. Some 30% plus of the child deaths can be attributed, at least in part or in whole, to problems with undernutrition. So we couldn't even begin to challenge the biggest problems in attaining the Millennium Development Goals without addressing the issue of nutrition. So where are we? How difficult is the problem? What is it going to take to address the problem? Well, one of the remarkable success stories in this area is really the story of the Global Alliance for Improved Nutrition, which Jay Naidu just described. This program, which at its sort of fullest capacity will be providing access to fortified foods to 650 million children and others who are undernourished. And the overall investment to make this possible is somewhere in the neighborhood of $100 million. This is a small amount of money. Now, this isn't to say $100 million is going to solve the whole problem, but when you think about the billions that are going into the Global Alliance for Vaccines and Immunizations, or the billions that are going into the Global Fund to fight AIDS, TB, and malaria, you realize that the opportunity in nutrition is a wonderful one, because with a small amount of money we can have a huge impact. And in fact, all the money going into addressing MDG 4 and 5 is probably not going to be productive unless we address this problem of nutrition. So we in the Gates Foundation have given a great deal of thought to a nutrition strategy. Our group has spent over a year thinking directly about where we can have an impact on nutrition and how we can have an impact on nutrition. And they have created a very ambitious strategy which focuses on research into new knowledge in nutrition and to key areas that deal with micronutrients and complementary feeding. Now, all components of this are important, but one that I would like to highlight is the importance of new knowledge. In fact, as much as we know about food, we know very little about the basis, the science of food. We know how food is absorbed, but actually in presenting the strategy, Bill Gates, who likes to ask difficult and probing questions, said, now tell me, what is a micronutrient? What defines what is a micronutrient? How is it that zinc acts? Now, you know, my background in enzymology and molecular biology, I could say, well, you know, there are some enzymes that require zinc. There are some proteins in which zinc is a very important component. Zinc plays a very important role in the transcriptional regulation of some genes. But that was a very far cry from an answer to why we need zinc. And in a sense, the nutrition community has been a little bit of a fractious community. The reason why is the less you know, the more your opinions count. So, in point of fact, we need new knowledge in nutrition. And we have to invest in this, because that will allow the other investments we make in nutrition to be wisely and strategically placed. But having said that, the two other key pillars, micronutrients for what we know about them, and fortification with micronutrients, and complementary feeding, are interventions that we know strategically placed can have a huge impact on human life. So our program is a relatively modest one to begin with, but it's over $500 million over the next 5 years, and we think this is critical to making a difference in this field. But by no means is this going to be enough. By no means are we going to be able to feed all the people in the world with this money. What we have to do is be strategic, place the money where it can make the most difference, really, and join others to be partners with us. The players who have been there for a long time, the World Bank, USAID, UNICEF, bilateral players from all over the world, and private industry, because we need all of the partners with us as we address this problem of undernutrition to save the lives of children and mothers. So I'll stop here. Thank you very much, and thank all of you for making this program possible.
Thank you, Dr. Yamada. We're going to open the floor to questions now. I have a few brief instructions. If you're in this auditorium, please signal to one of the staff members on the sides of the room, people raising their hands energetically right now, and they will pass a microphone to you. Please use the microphone. Identify yourself. Please tell us who you are and where you're from. If you're in the satellite room, a staff person will be identifying him or herself to you right now. Please pass your questions to that person who will ensure that they find their way to us. If you are on the phone or watching on the web, please email your question to Joe Wagner, Joe.Wagner @gmmb.com, and it too will find its way to us. So let's have some questions.
Jill Gay, Consultant Change. 2 quick questions. In looking at why women don't breastfeed, will you be looking or doing work on how women's work in the workplace is impacted, why they might not be able to breastfeed in the workplace? And secondly, for the young girl child, how does malnutrition in the early years affect malnutrition during pregnancy and postpartum?
Who'd like to take that question? Bob will be my default answerer.
Well, the first one on breastfeeding. Certainly, there are effective strategies to promote breastfeeding, peer counseling. I mean, if there are issues related to women in the workplace, they have to be addressed. I don't think there's a simple solution that I could say will work everywhere. But I think the success with breastfeeding promotion, especially exclusive breastfeeding, has been quite good, and in some places has gone fairly large scale. I think it needs to be expanded very much, but I really am optimistic that that's something that can be affected. The issues on undernutrition in childhood and pregnancy, I think, are real. There are issues of maternal size. We do address some aspects that might affect maternal mortality with very short stature women who may have obstructed labor. There may be other aspects we may not understand so well, long-term consequences of undernutrition that carry over into pregnancy, especially with adolescent pregnancies. So I think there are issues, but I don't know that we dealt with them in very great detail in the series.
Sorry, who's next? I can't see. Thank you.
Good morning. My name is Dr. Ellen Ruscombe. I'm a scholar here at the Wilson Center. Congratulations to all of you on a fantastic work accomplished, extremely important. It seems to me that the problem of undernutrition has been presented as, without any surprise, really a poverty-based issue in the countries that you've highlighted. And as Dr. Black highlighted, that the chronic health, social, and economic problems linked with child undernourishment, developing countries' health systems are unable to absorb the shocks that will come with this for decades to come and don't have the capacity, particularly in countries where public health systems have been privatized since the 1980s. ILO household studies in 13 developing countries found that 80% of people said that they had no access whatsoever to basic health services, and that paying for health services is the #1 reason for households falling into debt. My question to the panelists is, and perhaps rather bold, but would you support a shift in the international development approach to the interventions that have been described into an overarching economic development approach that would be based on principles of universalism, with a move away from means-tested benefits toward creating real national social protection systems in all countries with a floor through which no one can fall? Thank you.
I think that's a World Bank question. I think Joy is.
Jay?
Is this working?
Yes, it should be on.
I can, ideally, of course, that is what would make sense. But trying to have universal economic growth, which is really what you are implying, and building the type of capacity that is required in country to attain that. I think earlier on in my presentation, I alluded to the fact that we have actually done some research which indicates that sustained growth of up to 2.5% per capita GDP in developing countries would result in about a 27% reduction in malnutrition. But between now and, well, between 1990 and 2015. And this is a 2.5% growth. So you actually, and in order to get that, to double that or to treble that, you need substantial investment in human capital. You need substantial growth in the capacity of institutions. And you need a substantial investment in communities as well, and empowering the communities economically in order for them to be able to participate in economic growth opportunities. And that is a tremendous exercise. Of course, it can work, but it is going to take such a long time that the most prudent thing to do is to invest directly in nutrition related areas that are going to actually enhance the gains that you are going to have in nutrition. So sort of like the micronutrients, vitamin A supplementation in schools, the iron supplementation for populations, iodine for women. You know, these are these interventions that we are talking about here. In the short term, that is the best. Short and medium term. In long term, of course, your solution is the best and is the most sustainable.
Could I just add a few points to that? You know, the issue about breastfeeding at the workplace is really about labor standards. And what we should insist on across the world is that labor standards already agreed at the ILO need to be implemented. And here it's very important. I know in the 80s when we were trade union organizers, we were winning the right of women, even under apartheid, to have 3 months of paid leave as maternity leave, and in a period in which they could exclusively breastfeed. So today what we've got to ask is whether international companies who operate in countries where politically governments will not respect labor standards, whether those companies can be brought to account. And they can be brought to account in a whole range of different ways, whether it's through the global compact commitments they make, or whether it's through the pressures and advocacy of ordinary people in these countries where these companies come from. So I think it's very clear. It can be done, and it should be done. The second is that if one look at it, and the point that I raised in my input was that the linkages between nutrition and the broader challenges of development that we face. One of the most important things about dealing with the nutrition agenda is to take it out of the hands of nutritionists. And I think this is the fractious committee that has, in fact, curtailed our ability to deal with the challenges of nutrition on a global scale. So if one begins to extrapolate the issue that the speaker raised, for example, trade, agricultural trade, is fundamentally important about putting disposable income in the pockets of poor people who can have that income to determine the type of nutrition they want to have in their families. So ultimately, our nutrition agenda should be driven by what people who are most affected by undernutrition want to do. You don't have to teach a mother about good nutrition. They know what to do, but they permanently undermined by the fact that there are some important interventions that could be made. For example, on trade, the issue on international development cooperation. And I think we're beginning to make progress today. That even on the point of donor contributions, the new paradigm of thinking is that when you're making an investment, what is your exit strategy? How do we ensure there is sustainability? And therefore, these new types of partnership, the new thinking, the new models of development are things that really need to be brought forward. And we can only do that if we involve people to work with those grassroots organizations, with the private sector, and the new model of international development to try and remove the scourge of undernutrition.
Yes, please.
Yeah, thank you. Chessa Lutter, Pan American Health Organization. Thanks very much to the team that put together this wonderful report. I think it's going to make a huge difference for our work. And also to the Bill and Melinda Gates Foundation. It's really, again, important that this kind of work be supported. I have two questions. Well, first I want to also thank Dr. Naidu for his comments, particularly with respect to support for maternity leave globally, because I think too often we do put it in the hands of the mother, the onus on the mother, and fail to recognize the responsibility through private and public interventions to ensure that the environments that we create are most conducive to good nutrition. So I think that's very important. Thank you. My two questions, the first one, really a technical one. If the interventions you mentioned, breastfeeding, complementary feeding, vitamin A and zinc, can reduce stunting by 1/3, where's the other 2/3 related to? I assume some of it's related to morbidity, some of it may be intergenerational effects, but it strikes me as kind of a low number, since those are the key interventions that we would think would more or less, well, morbidity and intergenerational, but I'd really like to have your thoughts on that. The second one, perhaps more challenging, and I'm intrigued by your pyramid about how our fractious community can be more effective. And I'm curious, were there any discussions about how to actually operationalize that? Because that's, the pyramid's very pretty, but unless we can operationalize it, it's not going to get us too far. Thank you very much.
That's two easy questions for Bob.
Well, Jess, I guess the answer to the first is that in this series we reviewed the evidence of how effective interventions have been. So it wasn't, as we had done previously in the child survival series, saying, well, if breastfeeding were optimized, we would get this effect, which would be a big effect. But how effective have the interventions been? Now, for breastfeeding, they've been fairly effective. I can honestly say for complementary feeding interventions, we have been rather disappointed that the effect size has not been very great. I think we can do better. I mean, this is the evidence that exists today. So this, to me, is not only an implementation issue, it is somewhat a research issue of how can we get better effects from complementary feeding. And that's potentially the largest effect, because it's not coming from breastfeeding per se. It's going to come from the other feeding aspects. So I think that's the major part. The other ones that you mentioned, intergenerational effects, sort of unquantified effects of infections. There are other ones that probably do play a role, but I think it's most of the intervention effectiveness that is just not there yet in the way we'd like to be. Even if you include those situations, say with conditional cash transfers and food supplements, even then the effect sizes are not very great. and not as great as we'd like. And so, you know, there is some room for progress in you know what we can do now, but I think for further research as well. Now, so global governance. I'm going to throw that out to some of the others here because I think we mostly just put up the challenge, and we had persons from various agencies involved in the writing team who did contribute ideas, but I don't think there's any solution proposed, nor I think would it have been appropriate for us because we're largely coming from an academic kind of approach to this. I think this gets into the bigger realms of institutional mandates and politics, and I would like to hear from some of the others if they do have ideas, because they're the ones that really going to have to make this happen, not me in this case.
Ideas from the panelists? Kent, please.
Yeah, let me take on the first one just for a second, then I have a follow-up question to you on what exactly you were referring to in the second. But you asked, where are these other deaths coming from? Often the global health experts use a figure of 2/3 of the deaths under 5 as being preventable by known interventions. We've talked about here ones that are affected in some way to undernutrition. But the things they would talk about in that other third that are preventable might have to do with mosquito nets and in preventing malaria. It could have to do with point of use, purification of water. It could have to do with inoculations and vaccines. The whole point is, and to me, the reason I said this was my favorite event of the week was because anytime you get a chance to talk about what in fact are known interventions, not downplaying at all the importance of new research to go after the other third, but when you're not scaled up appropriately even at present to deal with the known interventions that would save lives, seems like that's an obvious place to begin. And this raises an interesting point about how everything is connected that the woman over here brought up. She's absolutely right. All of this is interconnected. And that's why even the nutrition interventions are connected and can be connected, and when the programs are done right, are connected to the other interventions. The place where the women receive the nutrients or the folic acid or the oral rehydration therapy or the zinc or the A, all of these things that we relate to nutrition. It can also be the place they get the mosquito nets where their kids get vaccinated. It can be this child and maternal clinic, this point of contact. These interventions need to be connected. And the good, I think the international community understands that's trying to do it, but it is all connected. Now, your second point had to do, should there be better global health governance to get at all of this? Is that, I was mainly writing down an answer to your first point, but is that what you were referring to?
Well, yeah, or there have been discussions. I respect what Bob said about that wasn't necessarily for the group to come up with a proposal, but I was curious, were there discussions about how that...
Sorry, I think we need the microphone. Were there discussions about how operationalizing the pyramid would happen? Is that right?
Well, I mean, over the last 3 years since I've been at this position, I guess my biggest shock has been to discover just how much international cooperation and discussion there actually is. I think I assumed outside that the bilaterals weren't talking to each other, that they weren't working with the international relations, that people are all doing their own thing vertically, et cetera. I've been mainly impressed to discover how much genuine global commitment there is to working together when you get out into the field, how well the people know each other, et cetera. Now, there's all sorts of debate and discussion about how can we do a better job of coordinating, and do we need a new secretariat to do that, and this and the other. And there are all sorts of grandiose plans about all of that. But a lot of the practitioners, their eyes kind of glaze over when they hear about another secretariat. I mean, they feel like the global community knows what to do most of the time. There are agencies and secretariats that know what to do. I think a lot of the people I talk to on the ground who are actually doing the work say, please fund the players that are doing something and who are cooperating, rather than spend a lot of time trying to invent a new system. Now, that's what I hear from the people in the field. That said, we can always try to figure out a way to better coordinate, but I think sometimes we ought to not just talk about it, but we ought to work through entities that exist.
One last question.
Maybe just before that,
Right,
can
Joy.
I just add a little bit? I think this is a very important issue. All of us as a global community appreciate how critical it is to harmonize our efforts. and that the cost effectiveness of the investments that we make, whether that countries make, that all of us make, in order to address the MDGs and poverty, have to be harmonized in order for us to get a bang for our buck, and in order for us to actually get the results and outcomes that people need in countries. That is the bottom line, and that is absolutely critical. Now, when this was also emphasized in the Paris harmonization agenda. Now, there are lots of areas where we have harmonized, and we have seen the benefits of harmonization, like in the HIV/AIDS, in malaria, and it is obvious that we need that harmonization in nutrition as well. Now, one of the big challenges in harmonizing in nutrition, where we can maybe make initiatives such as GAIN more effective, is that there are lots of implications in terms of transport. I'll give you an example. In 2006, the World Bank invested $730 million in nutrition in our outlined countries, $730 million. But a lot of that did not just go to the micronutrient initiatives, even though we did have conditional cash transfers, social protection measures to incentivize the use of micronutrients. But we had to invest in transport in order to enhance the outcomes in nutrition. We had to invest in areas that were related more to water, for example, but linking the water, investment in water to food production and distribution. So what I'm trying to say is that it is absolutely critical that we link these. And I think we have a lot of lessons in harmonization that we can learn from. Even if we don't do another global secretariat, even if we strengthen the capacity of GAIN, whatever we do, we need to bring all these interrelated areas together in order to ensure that we get bang for buck in this particular area, most importantly, outcomes at country level. I think that really is the bottom line, and that's what we need to commit to.
One last question in the back, please.
Yes, good morning. I'll be brief, but definitely want to take time to. I'm Dr. Al Bartlett. I work for Dr. Hill as a senior advisor for child survival at USAID. To thank Dr. Black and the team for focusing on this issue and consolidating the evidence. We'll all stand on this as we move forward. It's going to be another important contribution, and also, of course, to Lancet for focusing international and political attention on this issue. Much needed. Thank you. That said, I would just hark back to the child survival series in the Lancet, which clearly, as this series does, laid out the problem and also identified the evidence-based interventions that we should all be supporting. And I think there was general consensus that the thin part of that series was the part about how you effectively get those interventions through programs to children who need them, the sort of donut hole in that whole concept of child survival. And I would say that with this series, that's perhaps even more of an issue. If, for example, a prime minister in a country reads this Lancet series and says, oh my gosh, you know, we've got a vitamin A program, it's pretty good, we're starting fortification, but we've got all these children that are stunted, and I've got to do something to keep them from being stunted by age 2. You all have to tell me, how do I take $20 million from my treasury and turn that into an effective program that is going to make a difference for those children? What do I do? Do I train somebody? Is it health workers in the health system? Is it community people? What do I do? How did Ethiopia reduce stunting significantly between their last two DHS surveys? What is a national program at scale to make a difference in the nutritional outcome of children by age 2? What does it look like? We may not know now, but we better find out, because that's the question that the people who have the money are going to need to be able to answer in order to put this evidence to work. Thanks.
Jay, would you, brief comment?
Yes, I think that Dr. Hill and the last speaker certainly, hit the nail on the head. I think there's not all gloom and doom. I think there is increasing evidence of collaboration, and GAIN is a perfect example of that. At the moment, we're involved in on micronutrient deficiency, we're involved in a whole 10-year strategy, which involves every single one of the players, the major players in the nutrition space, looking at costing, at advocacy, at a range of interventions that try to develop a sort of rational and coherent strategy on micronutrient deficiency. So I think there is increasing amount of work, and particularly the role, I must say, in this instance of the Gates Foundation and USAID, supporting new models of involving other players, particularly the private sector and then increasingly civil society, in mobilizing people towards taking up the issue. And the one thing I would say, in addition to trying to make this a big issue of the Prime Minister, we certainly need to target the Ministers of Finance. In the budgeting process, the democratization and the greater transparency and accountability in the budgeting process will lead to greater resource allocation. And if we're going to be sustainable, institutions and organizations that are playing an incredibly important role like USAID, the World Bank, and the Gates Foundation need an exit strategy. For us to have a sustainable program in South Africa, we need your help, but then we want you out, because we should be doing what we are responsible for, delivering a better life to our citizens as a